Hello and welcome to Module 3 of your 2014 Medical Treatment Guidelines Protocol Training. This module is designed for intermediates and paramedic level providers. Training was developed by the Department of Fire, Rescue, and Emergency Management Training Division, Lieutenant Matthew Shields and Lieutenant Mary Hart. We encourage you to follow along in your protocol book during this training. We're going to talk about all 54 protocols contained within the protocol book, and we're also going to talk about what other provider levels can do for the patient. That way, if care has started prior to your arrival, you will know what has already been done. Okay, so let's start with Protocol 1, the Universal Patient Care and Initial Patient Contact Protocol. This is a simple patient assessment protocol. There's a few parameters in here for all provider levels. We want to maintain an oxygen saturation greater than 94%. We want to assess capnography and maintain an end-tidal CO2 reading of 35 to 45 millimeters of mercury. We also want to get a glucose analysis and 12-lead EKG if indicated. And of course, we want our IMP level providers to interpret that 12-lead. Also, if IV is indicated, obtain IV access. Now, this protocol is going to break your patient down between trauma and medical. For trauma, it'll break it down even further into whether or not they had a significant mechanism of injury or not. And for your medical patient, whether or not they are unresponsive or responsive. Now, the terminal end of this protocol always asks you to exit to the appropriate protocol. Protocol 2 is our behavioral and patient restraint protocol, and of course, our priority in this emergency is whether or not the scene is safe. So for your treatment, all provider levels, we need to get a good assessment on these patients, including blood glucose analysis and history gathering to determine whether or not this behavioral emergency is caused by a medical condition. Also, we need to consider physical restraint. Our advanced through paramedic level, IV access if safe to do so, and for our INP level providers. If the patient is aggressive and a threat to self or others, and we are able to restrain the patient, we need to administer midazolam 2 to 5 milligrams IV, IO, IM, IN every 3 to 5 minutes as needed. Or also we have Haldol or haloperidol, 5 milligrams IM, 2 to 5 milligrams IM if age is greater than 65 years old. Now, if the patient has excited delirium syndrome, we want to start off with Haldol. Same dose, 5 milligrams IM, or 2 to 5 milligrams IM if they're over 65 years old, and then Versed, 2 to 5 milligrams IV, IO, IM, or IN every 3 to 5 minutes as needed. Okay, so let's take a look at haloperidol or Haldol, the first of our new medications within these protocols. Haldol is an antipsychotic and a neuroleptic. Its indication is for chemical restraint. There is a black box warning on Haldol. Patients with dementia-related psychosis who are treated with antipsychotics such as Haldol are at an increased risk for death. In short-term controlled trials, death in trials appear to be either cardiovascular in nature or infection. This medication is not approved for treatment of patients with dementia-related psychosis. Okay, so as we said before, Haldol is an antipsychotic and a neuroleptic. It reduces nervous tension by depressing nerve functions. Its action is to block the dopamine receptors in the brain responsible for mood and behavior. It also has some antiemetic properties. Its indications are for schizophrenia and psychosis. Contraindications, it's not to be used in the presence of other sedatives, such as Talwin overdose and pentazocine overdose. And pentazocine is an analgesic that is less addictive than morphine. Also, patients with Parkinson's disease. Side effects to Haldol are dystonic reaction, respiratory depression, seizures, insomnia, and hypotension. We also need to be on the lookout for orthostatic hypotension when we administer Haldol to our patients. The dose for Haldol, if they are less than 65 years old, is 5 milligrams IM. If they are greater than 65 years old, we're going to half that, give 2.5 milligrams IM. All right, just a few notes on Haldol. We consider Haldol for patients with a history of psychosis only, and Versed for patients presumed substance abuse. All patients who receive chemical restraint must be continuously monitored by ALS personnel. And of course, we do not position or transport any restrained patient in such a way that could impair the patient's respiratory or circulatory status. All right, protocol 3 is our cardiac arrest adult protocol, and there's something new in this protocol, continuous compression CPR, CC-CPR. This protocol starts off with a patient in sudden cardiac arrest. We're going to immediately go to 200 chest compressions, which is 2 minutes of CPR, 100 compressions a minute. We'll insert an OPA, and we're going to apply a non-rebreather mask at 100% oxygen. Rhythm analysis and a single shock without pulse check, and then continue on with 200 chest compressions, rhythm analysis again. Now at the top right-hand corner, there's a box that says as early as possible, and we're going to discuss that in the next slides. Okay, so for our cardiac arrest adult continuous compression CPR, like I said, 200 chest compressions, 2 minutes of CPR. We insert the OPA, apply non-rebreather mask at 100% oxygen, and we analyze the rhythm. Single shock if indicated, without a pulse check. Contraindications to continuous compression CPR are children under the age of 8 years old, known suspected overdose, respiratory cause of arrest, hypothermia, near drowning, and traumatic arrest. Of course, with these contraindications, if we already know the cause of arrest, we need to immediately reverse what's going on so we can hopefully get a pulse back in our patients. If this is the case, we begin standard CPR and or go to the appropriate protocol. Okay, also under Protocol 3, you have the ability to terminate resuscitative efforts after 25 minutes if your patient has not regained a pulse or had return of spontaneous circulation. Of course, you want to contact medical control, and in the policy section of these protocols, there is several guidelines that must be followed for discontinuing pre-hospital resuscitation. The first of which is the patient must be 18 years of age or older, or family of a minor is agreeable after consultation with medical control. Adequate CPR has been administered. Successful management of the airway with verification of device placement. Acceptable management techniques including intubation and supraglottic airway devices such as our King Airway. Arrest was not witnessed by EMS. No return of pulse at any time during resuscitation. No shock delivered during resuscitation. Minimum of 25 minutes of resuscitation must be attempted, and all EMS personnel involved in the patient's care agree that discontinuation of the resuscitation is appropriate. So if all of these criteria are not met and discontinuation of pre-hospital resuscitation is desired, we need to contact medical control. We need to be sure that we use all diagnostic tools available to us. End-tidal CO2 is the best indicator for ROSC, as well as pulse oximetry and an ECG. Also, at the top right-hand corner of Protocol 3, there is a box that says as early as possible. And for our advanced providers, as early as possible, they need to establish an airway with the blind insertion airway device. For the IMP level providers, it's either a King Airway or intubation, as well as IVIO, and also administering epinephrine 1 milligram 1 to 10,000 every 3 to 5 minutes. As early as possible means as long as it does not interfere with continuous compressions. All right, Protocol 4 is our cardiac arrest pediatric protocol. No real change from your current protocols you're working under. It does break this down into neonate and child. So for your newborn to 31 days or less, you're going to exit to the newborn neonatal resuscitation protocol, Protocol 42. If they're 1 month to 8 years old, this is the protocol you're going to use. Of course, for our I and P providers, consider bilateral chest decompression and traumatic arrest. And at any time, a return of spontaneous circulation, we want to go to the post-resuscitative care protocol for pediatrics, Protocol 16. Protocol 5 is our epistaxis protocol, or a nosebleed protocol, and this protocol is broken down between whether or not your patient is a significant or multi-system trauma patient, and that's what's causing the nosebleed, or whether or not this is just a nosebleed that's actively bleeding that you can't control with direct pressure. So we're going to ask the question, is it significant or multi-system trauma? If the answer is yes, we apply direct pressure and exit to our injury protocol. If the answer is no and it's still actively bleeding, we compress the nostrils with direct pressure and tilt the head forward into a position of comfort. If that doesn't stop the bleeding, then we're going to go on to one of our new medications, which is Afrin. We're going to talk about that in a minute. All right, Afrin, or oxymetazoline. This is a vasoconstrictor. It's used to control or prevent nasal bleeding. So if the patient has active bleeding after direct pressure, after tilting the head forward, we can't get the bleeding stopped, all provider levels are going to have the patient blow their nose, and we need to suction the active bleeding. The purpose of this is to clear out any blood clots so that the medication can reach the blood vessel and constrict and hopefully slow or stop the bleeding. So for our adult patients, Afrin, 2 to 4 sprays to the bleeding nostril. For our pediatric patients, 1 to 2 sprays to the bleeding nostril. Now we want to avoid Afrin in patients who have a diastolic blood pressure greater than 110 millimeters of mercury, or they have a history of coronary artery disease. All right, protocol 6 is our fever protocol, and we will be breaking fevers that are greater than 100.4 degrees Fahrenheit or 38 degrees Celsius. Our EMTs will be administering to adults only ibuprofen and acetaminophen to do so. All right, so a new medication we're going to be carrying out there is ibuprofen, and for the EMT, this is adult only, but for all other provider levels, we will be administering ibuprofen to break fevers. This comes in a concentration mixed 100 milligrams in 5 mLs. So adult patients with a fever greater than 100.4 Fahrenheit or 38 degrees Celsius, we want to administer 400 milligrams PO. So that would be 4 medication cups, and these are about the size of a coffee creamer. And as I said, they come mixed 100 milligrams in 5 mLs. Now, we need to be on the lookout for NSAID-induced asthma. About 8 to 20% of all asthma patients can have an asthma attack when taking NSAIDs, or non-steroidal anti-inflammatory drugs. All right, so ibuprofen. It is a non-steroidal anti-inflammatory drug, and it has antipyretic qualities. Indication is a fever greater than 100.4 or 38 degrees Celsius. Of course, we're not going to administer this in the setting of environmental heat emergencies. Contraindications to ibuprofen are hypersensitivity, asthma, severe renal or hepatic disease, and our side effects are anaphylaxis, rash, GI bleeding, nausea, tinnitus, and headache. Okay, let's talk about acetaminophen, and for adult only for our EMTs, but for all other levels, we're going to be administering Tylenol or acetaminophen to break a fever, so advanced up to paramedic can give this also to pediatric patients. The adult dose is 650 milligrams, and we've made this easy because it comes mixed 650 milligrams in 20.3 milliliters. Now this comes in a cup that's about the size of a yogurt container. All right, so if ibuprofen was previously administered, that's when we want to give acetaminophen, and vice versa, if acetaminophen was previously administered. Now, when we say previously administered, what we're talking about is the patient tells you, I took Tylenol or I took ibuprofen. We want to switch and give the opposite drug. All right, so your patient has taken ibuprofen, so you'll administer acetaminophen or Tylenol. And for the EMT, like I said, that's adult only. Adult patients with fever greater than 100.4 Fahrenheit, 38 degrees Celsius, and you have not administered ibuprofen or they have not taken ibuprofen prior to your arrival. Again, 650 milligrams PO. Let's talk about Tylenol or acetaminophen. It is an antipyretic and it is a non-opioid analgesic. Its indications, again, are fever 100.4 Fahrenheit, 38 degrees Celsius in the absence of an environmental heat emergency. Contraindications are hypersensitivity, intolerance to alcohol, saccharin, table sugar, and yellow dye, and that's how the medication comes packaged and mixed. Precautions are anemia, hepatic or renal disease, chronic alcoholism, pregnancy, lactation, and elderly patients. And our side effects are drowsiness, rash, urticaria, nausea, vomiting, and abdominal pain. Okay, so let's take a look at our pediatric doses for our advanced through paramedic providers. Ibuprofen pediatric dose is, they must be greater than 6 months old. It's 10 milligrams per kilogram PO. Of course, if ibuprofen was not previously administered by the patient or you. Acetaminophen, pediatric, we need to see the color-coded list in the back of the protocols, the Broslow tapes, but the dose is 15 milligrams per kilogram PO. Okay, Protocol 7 is our pain control protocol, and within this protocol, the EMT will have the option of treating pain, mild pain, with ibuprofen, acetaminophen, or aspirin. For our I&P level providers, you will have fentanyl, ketamine, and morphine at your disposal. Okay, let's take a look first at the first arm of pain management, pain treatment, and that is the PO medications. And you can use both arms of this protocol. You can use PO meds as well as IV, IO, IM, IN medications for pain management. So ibuprofen at 400 milligrams PO, or acetaminophen at 650 milligrams PO, or aspirin at 650 milligrams PO. Of course, we do not want to administer any PO medications for patients who may need surgical intervention for injuries, illness such as open fractures, fractured deformities, headaches, or abdominal pain. And again, the same contraindications apply to ibuprofen, acetaminophen, and aspirin as they do in other protocols. So ibuprofen should not be used in patients with known renal disease or renal transplant, in patients who have known drug allergies to NSAIDs, or patients with active bleeding, headaches, abdominal pain, stomach ulcers, or in patients who may need surgical intervention, as we've already discussed. Also, we don't want to administer acetaminophen to patients with a history of liver disease. So for our I&P providers, for mild pain, the first arm of pain management treatment with our PO medications, pediatric patients greater than 6 months old, ibuprofen at 10 milligrams per kilogram PO, or acetaminophen at 15 milligrams per kilogram PO. Okay, so our moderate to severe pain, our I&P level providers, you will have fentanyl at 1 to 1.5 micrograms per kilogram. The routes of administration are IV, IO, IM, or IN, and your max dose is 2 mics per kilogram, adults and peds. And you can add, if needed, ketamine, 0.1 to 0.5 milligrams per kilogram, adult. Paramedics can administer ketamine to pediatric patients, 0.1 to 0.2 milligrams per kilogram. I&P providers will continue to use morphine if indicated at 2 to 4 milligrams IV, IO, IM every 10 minutes to a max of 10 milligrams. And our paramedics can administer morphine to pediatric patients at 0.1 milligrams per kilogram, IV, IO, IM, max of 10 milligrams. And again, that is for our pediatric patients. Okay, so let's talk about the first of these two new medications in pain management. The first is fentanyl. It is a potent narcotic analgesic and a sedative, and the dose of about 100 micrograms is equal to 10 milligrams of morphine. However, there are some differences from morphine. Fentanyl has a short duration of analgesic activity. It lacks emetic activity and minimal hypotensive activity. So that makes fentanyl kind of the perfect drug for pre-hospital pain management. There are some contraindications: known hypersensitivity, bronchial asthma, a comatose patient with a possible head injury, brain tumors, concurrent patient use of a monoamino oxidizer inhibitor, and these are those first-generation antidepressant medications, and a systolic blood pressure less than 110 millimeters of mercury. All right, some precautions with fentanyl. Pregnant patients. Alcohol ingestion of your patient. This may increase the depressant effects. Side effects are analgesia, euphoria, constricted pupils or meiosis, bradycardia, respiratory depression, apnea, muscle rigidity, suppression of the cough reflex, anaphylaxis, bronchospasms, pruritus, urticaria, and asystole. Okay, so now we're going to focus on ketamine or Ketalar. Ketamine is used as a general anesthetic, and it has been for many years. However, we're going to be giving it at the sub-dissociative dose for use as an analgesic. Ketamine is a N-methyl D-aspartate receptor antagonist, commonly referred to as an NMDA receptor antagonist. What this will do is it'll block the NMDA receptor to produce a dissociative anesthesia. Of course, we're giving this at the sub-dissociative dose. The purpose of ketamine within the protocol is to relieve pain, not to induce a catatonic state. So our dose for adults of 0.1 to 0.5 milligrams per kilogram, and for our paramedics, 0.1 to 0.2 milligrams per kilogram for the pediatric patient. Contraindications are hypertension and hypersensitivity to the drug. The precautions we need to be on the lookout for is this may have additive or synergistic effects when other sedatives are present. And side effects are hypertension, flushing, palpitations, dry mouth, nausea, and vomiting. Now, how we're going to be carrying ketamine is in a mixture of 500 milligrams in 10 mLs, which is 50 milligrams per 1 ml. Okay, so here's a note on the hypertension caused by ketamine. You can have an elevation in blood pressure, and it begins shortly after injection. And usually returns to pre-anesthetic values within 15 minutes after the injection. In the majority of cases, the systolic and diastolic blood pressure peaks from 10% to 50% above pre-anesthetic levels shortly after induction of anesthesia. But the elevation can be higher or longer in individual cases. Okay, Protocol 8 is our pepper spray taser removal protocol, and we're really going to be focusing on the taser removal aspect of this in the skills portion of this protocol rollout. However, for the pepper spray, it is a basic irrigation of the face and eyes, removing any contaminated clothing. If they do have difficulty breathing, you're asked to exit to the appropriate protocol, which would be the respiratory distress protocol, 46 or 47. And if they have asthma, COPD history, we want to observe them for 20 minutes, follow appropriate protocol if indicated. Protocol 9 is a rehabilitation for responders protocol, and this is for our firefighters who are engaged in active firefighting operations. There are certain parameters within this protocol for fluid resuscitation, predicting a max heart rate, and what to do if we have signs of orthostatic hypotension. Also, it will refer you to the carbon monoxide smoke inhalation protocol, Protocol 23, if indicated. Okay, so let's look at orthostatic vital changes. For our advanced through paramedic providers, if we have a pulse increase of 20 beats per minute or a systolic drop of 20 millimeters of mercury in the blood pressure, we want to immediately infuse up to 2 liters normal saline until the heart rate returns to less than or equal to 100 beats a minute, and the systolic blood pressure is greater than or equal to 110 millimeters of mercury. Now, within this protocol, at the top right-hand corner, you do have the age-predicted 85% max heart rate chart. So, for example, a 20 to 25-year-old, 85% max heart rate is 170 beats a minute. The automatic transport criteria for our firefighters is chest pain complaints, cardiac arrhythmias, syncope, altered mental status, confusion, disorientation, shortness of breath unresolved by 10 minutes of high-flow oxygen, vital signs that have not returned to normal after 30 minutes of rest, any episode of vomiting or inability to hold fluids down, and obviously any request for transport. Now, some of our cooling techniques: removing the gear, cooling fans, ambient evaporative cooling, cold wet towels to the head and neck, and oral rehydration with water or balanced electrolytes and sugar sports drinks. All right, Protocol 10 is our spinal immobilization clearance protocol. And just a note on this protocol, your default is to always immobilize your patient. If there is any doubt, we immobilize. This protocol is based upon 7 assessment findings or questions. If the answer to any of those 7 questions is yes, then we will immobilize the patient with long board, cervical spine immobilization collar, and cervical immobilization devices or head blocks in place. All right, again, default is always to immobilize. And just a note, in the very young or the very old, a normal exam may not be sufficient to rule out a spinal injury. So there is an acronym that's going to help us remember this assessment, and that is NSAID, usually stands for nonsteroidal anti-inflammatory drugs. However, in this case, the N will be the neurological exam. We're going to look for focal deficits such as tingling, reduced strength, or numbness in the extremity. The S stands for significant mechanism or extreme age, so the very young, the very old, or there's a significant mechanism of injury. The A is alertness. Is the patient oriented to person, place, time, and event? Any changes in alertness with the incident? I is for intoxication. Is there any indication that the person is intoxicated, impaired decision-making ability? Distracting injuries for the D. Is there any other injury producing pain in the patient? Any injury which the patient seems to focus on, and we determine this by them rating that pain at a 6 or greater on a scale of 0 to 10. And the S is for the spinal exam. We're looking for point tenderness in the spinal process, or spinal process tenderness with range of motion. Each of the 7 cervical spinal processes must be palpated during the exam. If the answer to any of these is yes, we will immobilize the patient. Okay, so protocol 11 is our airway protocol and is a general protocol in dealing with an airway. It gives us kind of the tools that we have at our disposal. The first of which is the King Airway, or the blind insertion airway device, which is for all provider levels. And next is the intubation procedures for the I provider. It's oral tracheal intubation over the age of 12 years old. And for the P provider, it is any age oral tracheal intubation. For the P provider, you also have adult nasotracheal intubation. Patient must be over 12 years of age. And you have airway cricothyrotomy procedures. We're also going to talk about post-intubation sedation if needed. So just to review, our EMT through paramedic level, basic airway maneuvers, spinal immobilization procedures if indicated, and the blind insertion airway device, or the King Airway. For our IMP level providers, direct laryngoscopy for our foreign bodies, and needle decompression for our tension pneumothoraxes. And for our P providers, airway cricothyrotomy procedures and post-intubation sedation. Okay, paramedic level providers. Let's take a look at this post-intubation sedation. How we do this is we administer fentanyl at 100 to 150 micrograms, and this is not weight-based, IV or IO, and or administer ketamine, 2 milligrams per kilogram, IV or IO. Now that ketamine dose is the dissociative anesthetic dose. Your patient is already intubated. The post-intubation sedation for pediatric patients, we're going to administer ketamine at 0.1 to 1.5 milligrams per kilogram, IV or IO. Just be aware that when we administer fentanyl and ketamine together, we need to be on the lookout for a synergistic effect. Protocol 12 is an airway failed protocol. It basically gives us guidance on when to, for our paramedic providers, head to the airway cricothyrotomy procedure. But also don't forget, for our I and P level providers, we do have the option of the blind insertion airway device if intubation is unsuccessful. Now there's a note on this protocol: 2 failed intubation attempts by the most proficient technician on scene, or the patient has anatomy that's inconsistent with intubation attempts. That's when we use the airway failed protocol. Each attempt should include a change in approach or equipment, and for intubation, no more than 3 attempts total. Okay, for all provider levels, don't forget, if indicated, insert the blind insertion airway device. If unsuccessful, call for ALS, and of course we are using the King Airway for our BIAD. Okay, so for our paramedic providers in the airway failed protocol, protocol 12, airway cricothyrotomy procedures. When is this indicated? This is indicated when you are unable to bag your patient and maintain an SpO2 of 94% and a normal end tidal of 35 to 45. It's when you have failed in 3 intubation attempts and you have failed to insert the blind insertion airway device or the King Airway. Also, if your patient has significant facial trauma, swelling, distortion of the airway, and time does not allow for other airway procedures, you are indicated to perform an airway cricothyrotomy, whether that be surgical or a needle cric. And again, we're going to cover both of these extensively in the skills training. All right, protocol 13 is our cardiac arrest asystole PEA protocol for adult patients. All of our cardiac arrest protocols follow the ACLS guidelines. So no real change here in your treatment from your current protocols. Just a reminder, we need to consider the causes of our cardiac arrest, so our H's and T's, considering all possible causes listed in the differential, and survival is based on identifying and correcting that cause of cardiac arrest. Consider a discussion with medical control. Protocol 14 is our cardiac arrest asystole PEA pediatric, and again, covering all PALS and ACLS guidelines. No real change from your current protocols you're working under now. At any time, if you do have a return of spontaneous circulation in either of these protocols, you need to go to the post-resuscitation care protocol. And for pediatric, it's protocol 16. For adult, it's protocol 15. All right, also consider bilateral chest decompression in traumatic arrest for both adult and pediatric patients, and once again, refer to the appropriate protocol for return of spontaneous circulation. Okay, so here's the post-resuscitation care protocol for adults, and we're going to cover this extensively in the next slides. For our advanced providers, if we do regain a pulse or have return of spontaneous circulation in our cardiac arrest patients, our advanced through paramedic providers, we need to focus on maintaining that blood pressure greater than 90 millimeters of mercury systolic, and we do this by IV normal saline boluses of 30 milliliters per kilogram to a max of 2 liters. Our INP level providers also have the option of administering dopamine at 5 to 20 micrograms per kilogram a minute to maintain that blood pressure again at 90 millimeters of mercury systolic. And our paramedic level providers have the option of post-intubation sedation. If your patient starts to come around, starts to chew on the tube, paramedics have the ability to give fentanyl 100 to 150 micrograms IV-IO and or ketamine 2 milligrams per kilogram IV-IO. And remember, the pediatric dose for post-intubation sedation is ketamine 0.1 to 1.5 milligrams per kilogram IV-IO. Protocol 16 is the post-resuscitative care pediatric protocol. Now, this protocol is based on blood pressure, blood glucose, and heart rate. No real change from your current protocols except for the post-intubation sedation if needed. And once again, if our patient has a return of spontaneous circulation, our INP level providers will look at their blood pressure. And remember, hypotension is age-based. So normal saline boluses at 10 milliliters per kilogram if the lungs are clear, IV-IO, and dopamine 5 to 10 mics per kg per minute, IV-IO. And again, to review, the ketamine dose for post-intubation sedation is 0.1 to 1.5 milligrams per kilogram IV-IO. Just a note on ventilating your pediatric patients, hyperventilation is a significant cause of hypotension. Recurrence of cardiac arrest in post-resuscitation phase must be avoided. So we can do this by maintaining that appropriate end tidal of 35 to 45. All right, protocol 17, ventricular fibrillation and ventricular tachycardia adult. No real change from your current protocols except for your antiarrhythmic is no longer lidocaine, it is now amiodarone. ACLS procedures shall be followed in all cases of cardiac arrest. Just the notes here, again, at any time, if we have ROSC, go to the post-resuscitative care protocol. Adequate ventilations and CPR are major buffer agents in cardiac arrest, and sodium bicarb is not recommended for routine use in cardiac arrest. And, of course, we need to consider bilateral chest decompression in traumatic arrest. All right, so let's talk about amiodarone, one of our new drugs we're going to be carrying. For VFib pulseless VTAC, the initial dose of amiodarone is 300 milligrams IV-IO, and it can be repeated at 150 milligrams IV-IO if refractory. Now, refractory means obviously resistant to treatment. The way we're going to be carrying amiodarone is 150 milligrams in 3 mLs. Okay, so what is amiodarone? It is an antiarrhythmic. It's indicated in treatment of ventricular arrhythmias and atrial fibrillation. Actions is it prolongs the action potential duration in all cardiac tissue. Contraindications to administering amiodarone is cardiogenic shock, sinus node dysfunction resulting in marked bradycardia, symptomatic bradycardia, second or third degree AV blocks, and known hypersensitivity to the medication. Precautions are heart failure. Side effects are hypotension, bradycardia, increased ventricular beats, prolonged P to R, prolonged QRS complexes, and prolonged QT intervals, dyspnea, and cough. Amiodarone basically slows down the conduction in all aspects of the electricity in the heart. Okay, so for our intermediate and paramedic providers, if amiodarone converts your patient's lethal rhythm, we need to hang a maintenance infusion. And the dose of our amiodarone maintenance infusion is 1 milligram a minute. Now, to do this, we will mix 100 milligrams of amiodarone in 100 milliliters of D5W. Remember, the amiodarone is coming in a concentration of 100 milligrams in 3 mLs. So 2 mLs will be 100 milligrams. And of course, remember, reversing torsades de poids, mag sulfate is our drug of choice, and that is at 2 grams IV-IO. Protocol 18 is our VFib VTAC pediatric protocol. No real change in our treatment other than our chief antiarrhythmic is amiodarone. And the dose of amiodarone for our pediatric patients is 5 milligrams per kilogram IV-IO to a max of 300 milligrams. You may repeat 5 milligrams per kilogram in 5 minutes. Maximum subsequent doses of 150 milligrams and a maximum total dose of 15 milligrams per kilogram. So you may give your second dose twice. So an initial dose of 5 mg per kg, repeat dose of 5 milligrams per kilogram, and a repeat dose of 5 milligrams per kilogram. And also, to reverse torsades de poids in our pediatric patients is mag sulfate, and the dose is 50 milligrams per kilogram IV-IO, and you may repeat every 5 minutes to a maximum of 2 grams. If suspected hyperkalemia, diabetic ketoacidosis, or overdose of tricyclic antidepressants, aspirin, cocaine, or diphenhydramine, we want to administer sodium bicarbonate, 1 milliequivalent per kilogram IV-IO. Protocol 19 is our cold exposure protocol, and it's broke down between hypothermia and frostbite, whether or not it is localized cold injury or a systemic cold injury, and no real change from your treatment in your current protocols. Just some notes on Protocol 19. No patient is dead until warm and dead. Hypothermia is defined as 35 degrees Celsius or 95 degrees Fahrenheit. And hypothermia may produce severe bradycardia, so we need to take at least 45 seconds to palpate and locate that pulse. Also, active warming with hot packs. We want to consider withholding CPR if the patient has an organized rhythm or has other signs of life. Intubation can cause ventricular fibrillation, so it should be done gently by the most experienced provider. Now, if the patient's temperature is less than 86 degrees Fahrenheit or 30 degrees Celsius, only defibrillate one time if required. Below 30 degrees Celsius or 86 degrees Fahrenheit, we need to contact medical control before administering any antiarrhythmic medications. And also, if they're below 30 degrees Celsius or 86 degrees Fahrenheit, we need to contact medical control before pacing. Okay, Protocol 20 is our heat exposure heat stroke protocol, and this protocol really is a good reference for the provider. It breaks down the differences between heat cramps, heat exhaustion, and heat stroke. Okay, so in Protocol 20 for heat exhaustion and heat stroke, our advanced through paramedic level providers are going to focus on maintaining a systolic blood pressure greater than 90 millimeters of mercury. We're going to do this by administering boluses, 500 mLs. And you can repeat up to a max of 2 liters. Of course, we're going to assess the patient for fluid overload while doing so. Just a note that sweating generally disappears at a body temperature of 104 degrees Fahrenheit or 40 degrees Celsius. And remember, we are treating a heat emergency due to environmental extremes, so the use of antipyretics are not indicated in this protocol. Predisposed to hypothermia, patients who take tricyclic antidepressants, patients who take antipsychotics such as phenothiazines, anticholinergic medications, patients who abuse alcohol, cocaine, salicylates, and amphetamine. And again, sweating generally disappears at 40 degrees Celsius or 100.4 degrees Fahrenheit. All right, heat cramps are not associated with elevated body temperature. Heat exhaustion vitals consist of tachycardia, hypotension, and elevated body temperature. Now, heat stroke vitals consist of the same tachycardia, hypotension, and elevated body temperature greater than 104 degrees Fahrenheit, as well as your patient will exhibit signs of altered mental status. Protocol 21 is our bites and envenomation on land protocol. It covers snake bites, spider bites, bees and wasps, dog, cat, and human bites, and no real change in your treatment from your current protocols. Protocol 22 is our burns protocol. It's broken down between minor burns, serious burns, and critical burns. Okay, so for Protocol 22 and our burns, our INP level providers will be administering nebulized epinephrine to patients who show signs of smoke inhalation and they're experiencing difficulty breathing. They're going to administer 2 milligrams of 1 to 1,000 mixed with 3 mLs of normal saline, and they're going to nebulize the epinephrine to the patient. Also within this protocol, there is the Parkland formula for patients with greater than 15% total body surface area burned, and this is a condensed Parkland formula, 0.25 milliliters per kilogram times the percentage of total body surface area burned. And this is the amount of fluid we're going to give per hour for the first 8 hours. Okay, just to talk about the PEARLS section in the burns protocol. Patients that require direct transport to a burn center or transfer once seen at a local facility where the patient can be stabilized are as follows. Greater than 5 to 15% total body surface area, second or third degree burns. Greater than 5% total body surface area, third degree burns for any age group. Any patient with circumferential burns. Electrical or lightning burns. Suspicion of abuse or neglect. Inhalation injuries. Chemical burns. Burns to face, hands, feet, perineum, and genitalia. Again, these are the patients that require direct transport to a burn center or transfer once seen at a local facility where they can be stabilized. Remember, burn patients are prone to hypothermia. We never administer any IM pain medications to a burn patient. We want to assure proper decontamination of all patient providers and equipment and contact the receiving facility as soon as possible. Now, your burn center verifications. VCU is an adult and peds burn center in Richmond, Virginia. Washington Hospital Center is an adult burn center in Washington, D.C. North Carolina JC's Medical Center is adult and peds in Chapel Hill, North Carolina. Johns Hopkins Regional Burn Center is adult in Baltimore, Maryland. And Wake Forest University Baptist Medical Center is adult and peds in Winston-Salem, North Carolina. And, of course, remember for our burns patients, because of the distance to these burn centers, air medical transport should be utilized. Okay, Protocol 23 is a new protocol here. It's a carbon monoxide smoke inhalation protocol. And we do have a new medication for our IMP level providers. Hydroxycobalamin is given for cyanide exposure. Let's talk about hydroxycobalamin. Your dose is 70 milligrams per kilogram over 15 minutes. Indications are cyanide exposure. This is the antidote to cyanide poisoning. Hydroxycobalamin works by binding cyanide and forming cyanocobalamin for urinary excretion. Contraindications to administration of hydroxycobalamin is none in the settings of suspected cyanide toxicity. There are some side effects, however: redness of skin and mucous membranes, headache, dizziness, restlessness, eye and throat irritation, dyspnea, pulmonary edema, chest tightness, hypertension, tachycardia, palpitations, nausea and vomiting, diarrhea, abdominal pain, dysphagia, red urine, and hives. Okay, so let's take a look at some of those side effects. We give hydroxycobalamin for a high suspicion of cyanide poisoning. So if this patient was involved in a house fire, inhaled a lot of smoke, a lot of byproducts of combustion, we're going to administer at 70 milligrams per kilogram IVIO over 15 minutes. Maximum dose is 5 grams. We're going to consider CO and cyanide with any products of combustion. The first picture here on the left is the reddening of the skin after administration of hydroxycobalamin, and the picture on the right is the urine from that patient after hydroxycobalamin was administered. All right, Protocol 24 is our crush syndrome protocol. So for our advanced through paramedic providers for crush syndrome, it is very heavily focused on fluid resuscitation, normal saline boluses of 1 liter IV, and we want to consider a second line and an additional liter if the patient has been trapped for greater than 1 hour. Now, for our IMP level providers, we need to be looking on our EKG for peak T waves, a QRS that is greater than 0.12 seconds or 3 small squares, so a wide QRS, and the absence of P waves. Okay, so if the EKG abnormalities are present, that is the peak T waves, the wide QRS, and the absence of a P wave, our INP level providers are to administer sodium bicarbonate, 100 milliequivalents mixed in 1,000 mLs of normal saline, and they're going to infuse 100 to 150 milliliters an hour. Calcium chloride, 1 gram IV/IO over 3 minutes, and albuterol, 10 to 20 milligrams over 15 to 20 minutes. If no EKG abnormalities are present, but we still have a Crush syndrome patient, we need to administer sodium bicarbonate, 50 milliequivalents IV/IO immediately prior to extrication. Okay, so for pain management in our Crush syndrome patient, the doses are the same: fentanyl 1 to 1.5 micrograms per kilogram, IV/IO, IM, or IN, and we may repeat to a max of 2 micrograms per kilogram, and if needed, ketamine 0.1 to 0.5 milligrams per kilogram, IV. Also, Versed or midazolam 1 to 2 milligrams IV/IO, IM, or IN for anxiety if needed, and be aware of a possible synergistic effect. Protocol 25 is an extremity injury protocol. No real change from your current protocols in treatment of your patient with injuries to their extremities. Protocol 26 is a head injury protocol. Okay, so within this protocol, there's a reminder that we do not hyperventilate patients. We may only increase ventilations in the instance of brain herniation syndrome. So our normal ventilations, adults 8 to 10 a minute, pediatric 12 to 20 a minute, and infants 20 to 25 a minute, to maintain an end-tidal CO2 normal reading of 35 to 45 millimeters of mercury. Now, if we have a patient with a head injury showing signs of brain herniation, such as unilateral or bilateral dilation of pupils, posturing, decorticate, or decerebrate posturing, we want to increase our ventilatory rate. Adults 14 to 16, peds 20 to 25, infants 25 to 30. And we want to maintain a lower end-tidal reading of 30 to 35 millimeters of mercury. Same thing is true for patients who show signs of increased intracranial pressure, such as Cushing's reflex with hypertension, bradycardia, and irregular respirations. So the reason we do this, why do we increase the ventilations? Well, increasing the ventilations decreases the carbon dioxide level in the body. Carbon dioxide dilates the cerebral blood vessels. If we dilate the cerebral blood vessels, we increase the blood volume in the intracranial vault and therefore increase the intracranial pressure. So we want to keep that CO2 level down. Of course, hyperventilation must be avoided. Okay, Protocol 27 is a multi-system trauma protocol, and it's broken down between abnormal and normal vital signs perfusion and GCS. No real change in your current treatments. Protocol 28 is an abdominal pain protocol, and of course our chief antiemetic that we're still carrying is ondansetron or Zofran. So just a few notes on abdominal pain. Abdominal pain in women of childbearing age should be treated as pregnancy-related until proven otherwise. The diagnosis of abdominal aneurysm should be considered with abdominal pain in patients who are over the age of 50. And we want to consider cardiac in nature in patients over 50, diabetic, and or women, especially when they have a complaint of upper abdominal pain. Okay, Protocol 29 is our allergic reaction anaphylaxis adult protocol. And it's broken down between your symptom severity. Are they mild, moderate, or severe? So for our mild allergic reaction patients, treatment will start with the advanced provider administering diphenhydramine at 25 to 50 milligrams IV or deep IM. For our moderate reactions, our EMTs can administer the EpiPen and albuterol without a prescription. Albuterol 2.5 milligrams in 3 mLs times 3 as needed. Our advanced providers, if they have not already given the diphenhydramine, will do so at 25 to 50 milligrams IV or deep IM and administer epinephrine 1 to 1,000, 0.3 to 0.5 milligrams IM. Also, our IMP level providers will have methylprednisolone or solumedrol and that is given at a dose of 125 milligrams IV or IO. Now we move on to our severe anaphylaxis or allergic reaction. Of course, if not already done so, the EMTs will administer the EpiPen and albuterol, same as in the moderate reactions. The advanced provider will administer the epinephrine, again 1 to 1,000, 0.3 to 0.5 milligrams IM every 5 minutes, and they can repeat this once, as well as diphenhydramine, 25 to 50 milligrams IV or deep IM. Now our IMP level providers will administer the methylprednisolone or Solumedrol at 125 milligrams IV or IO, and we have a new administration technique for epinephrine, and it's epinephrine 1 to 100,000, and that is 1 milliliter a minute for 10 minutes, IV or IO. Okay, so how do we get this epinephrine 1 to 100,000? Well, this is basically taking the place of epi infusion. A little bit simpler to do. If the patient does not respond to epinephrine IM and fluid resuscitation, IV epinephrine should be administered. So how do we do this? We take a Bristojet of epinephrine, a 1 to 10,000. What we're going to do is waste 9 mLs from the Bristojet. So that leaves us with 1 ml of 1 to 10,000 epinephrine. You're going to attach this Bristojet to the tubing, pinch the patient's side of the tubing, and draw back. What we're doing is filling that Bristojet with normal saline. So now we have 10 cc's or 10 mLs inside your Bristojet, and 1 ml was epinephrine 1 to 10,000. At this point, we have epinephrine 1 to 100,000. You're going to administer 1 ml a minute for 10 minutes. Protocol 30 is our allergic reaction anaphylaxis pediatric protocol, and it is broken down between mild, moderate, and severe. Okay, so for our mild allergic reaction for pediatric patients, our treatment starts at the IMP level with diphenhydramine at 1 milligram per kilogram IV or deep IM. For our moderate and severe, our EMT through paramedic, the EMT is going to administer that epinephrine auto-injector. If the patient is greater than 30 kilograms, they're going to give the adult EpiPen. If they're less than 30 kilograms, EpiPen Junior. They're also going to administer albuterol, 2.5 milligrams nebulized, and they're going to repeat as needed times 3. And that can be given by our EMTs and our advanced providers without a prescription. Now, at the IMP level, we're going to administer the epinephrine 1 to 1,000, 0.01 milligrams per kilogram IM, max dose of 0.3 milligrams. Diphenhydramine, 1 mg per kg, IV, IM, or IO. Solumedrol, 2 milligrams per kilogram, IV, IO, to a max of 125 milligrams. And, of course, our normal saline boluses of 20 mLs per kilogram. You may repeat to a max of 60 mLs per kilogram, so we may give 3 saline boluses. If no improvement, we are going to go to the epinephrine 1 to 100,000, and we're going to administer 1 milliliter per minute, same as the adult. Okay, protocol 31 is our altered mental status protocol, and again, this is really just used as an assessment tool. This protocol, every terminal point of this protocol asks you to exit to the appropriate protocol. No real change from your current treatments. Protocol 32 is our bradycardia adult protocol. Again, no real change from your current treatments. Still at the IMP level, considering atropine at 0.5 milligrams IV-IO, may repeat 3 to 5 minutes, as well as transcutaneous pacing, early and second and third degree AV blocks. Also consider dopamine, 5 to 20 micrograms per kilogram a minute, if no clinical response. Of course, this is for patients' heart rates less than 60 beats a minute and symptomatic, which includes chest pain, difficulty breathing, altered LOC, or signs of hypoperfusion. Again, before pacing, we want to consider sedating our patients with Versed at 2 to 4 milligrams IV-IO. Okay, protocol 33 is our bradycardia pediatric protocol, and this protocol is heavily based on bradycardia causing hypotension, altered mental status, and poor perfusion or shock. If the answer to that question is yes, then we need to assess the airway of our patient. Pediatric patients generally go into arrest due to airway problems, so if we do not have a patent airway and the patient is not oxygenating and ventilating properly, we need to exit to the airway protocol and secure an airway. If they are oxygenating and ventilating adequately and have a patent airway, then we need to consider underlying causes. And of course, we need to get a blood glucose analysis in our assessment, obtain IV access, and ECG. Okay, so if they continue poor perfusion or shock, we need to start with our normal saline boluses of 20 mLs per kilogram IV-IO, repeat as needed times 3, and we're going to go to our epinephrine 1 to 10,000. The dose is 0.01 milligrams per kilogram IV-IO. We may repeat every 3 to 5 minutes. All right, so if increased vagal tone is the cause for the bradycardia, then we will consider atropine. Dose is 0.02 milligrams per kilogram IV-IO, minimums of 0.1 milligram, and you may repeat in 5 minutes one time. Also consider external cardiac pacing. Of course, if we do have a suspected beta blocker or calcium channel blocker overdose, we want to refer to the overdose poisoning toxic ingestion protocol for pediatrics, and that is protocol 44. Protocol 34 is our cardiac chest pain protocol. Okay, so for our cardiac chest pain protocol, all provider levels will be acquiring a 12-lead ECG and administering aspirin, 324 milligrams, or 481 milligram tablets chewable. They will also be administering nitroglycerin, sublingual at 0.4 milligrams, every 5 minutes times 3 as needed. Of course, maintaining that systolic blood pressure greater than 90 millimeters of mercury. They can use the patient's prescribed nitro or the nitro that's in the BLS drug box. Our advanced through paramedic level providers are going to be administering the nitroglycerin sublingual as well as nitro paste. Maintaining a systolic blood pressure greater than 90 millimeters of mercury, they will administer 1 inch of the nitro paste. Also, normal saline boluses as needed, 250 mLs up to 1 liter. Now for the I and P level providers for pain, we'll be administering morphine, 2 to 5 milligrams IV-IO, or fentanyl, 1 microgram per kilogram IV-IO, IM, or IN. And also for hypotension, if needed, dopamine, 5 to 20 micrograms per kilogram a minute, IV-IO, to maintain a blood pressure. Okay, protocol 35 is a dialysis renal failure protocol, and this is based heavily on if any of the following are present: hemodialysis in the past 4 hours, serious signs and symptoms, systolic BP greater than 89 millimeters of mercury, and a blood sugar between 69 to 249. If the answer is yes, then we are going to assess the patient's ECG. We're looking for peak T waves and that wide QRS greater than 0.12 seconds. If these are present, we're going to administer the calcium chloride 1 gram IV-IO over 3 minutes and sodium bicarbonate 1 milliequivalent per kilogram IV-IO. So just a few notes on this. Do not take BP or start IVs in extremities which have active working shunts or fistulas in place. And always consider hyperkalemia in all dialysis and renal failure patients. And we see this by peak T waves and wide QRSs. IMP level again for the treatment. Calcium chloride 1 gram IV-IO over 3 minutes. Sodium bicarbonate 1 milliequivalent per kilogram IV-IO. Protocol 36 is our hypertension protocol. No new treatment within this protocol for hypertension in your patients. Just a note on hypertension, it's not uncommon, especially in an emergency setting. It's the body's natural response to stress or pain. A hypertensive emergency is based on blood pressure along with symptoms. These symptoms suggest an organ is suffering damage, such as an MI, a CVA, or renal failure. This is very difficult to determine in a pre-hospital setting in most cases. Aggressive treatment of hypertension can result in harm. Most patients, even with significant elevations in blood pressure, need only supportive care. Specific complaints such as chest pain, dyspnea, pulmonary edema, and altered mental status should be treated based on specific protocols and consultation with medical control. All right, protocol 37 is a hypoglycemia diabetic emergency protocol. No real change from your current protocols in treatment of your hypoglycemic or hyperglycemic patient. Protocol 38 is our hypotension shock adult protocol, and it's broken down between hypovolemic, cardiogenic, neurogenic, and septic shock. Your pressor of choice is dopamine still, and of course your saline boluses. Protocol 39 is a hypotension shock pediatric protocol. And first thing we're going to look at is our adequate ventilations and oxygenation, but we need to make sure that our patient is actually hypotensive. So hypotension age-specific vitals, we get that by the systolic blood pressure less than 70 plus 2 times the age equals poor perfusion and shock. So 70 plus 2 times the age, if the systolic is less than that number, we have a pediatric patient with poor perfusion. We're going to look at our adequate ventilations and oxygenation. If they are adequate and trauma is present, we're going to exit to the multi-system trauma protocol. If no trauma is present, we're going to establish our IV, obtain ECG, and we do want a blood glucose analysis. Now, if that blood glucose is within a normal range or greater than 60, we are going to continue with normal saline boluses at 20 milliliters per kilogram. Repeat as needed, times 3 to the effect of a systolic blood pressure greater than that 70 plus 2 times the age. And of course, we have dopamine as a consideration at 5 to 20 micrograms per kilogram a minute IV IO, again to maintain that normal systolic blood pressure greater than 70 plus 2 times the age. Okay, so let's take a look at lowest blood pressures by age. If the patient is a neonate or less than 31 days old, then the systolic blood pressure should be greater than 60 millimeters of mercury. If they are 31 days to 1 year, then it should be greater than 70 millimeters of mercury. And if they are 1 year and older, we use that mathematical equation of 70 plus 2 times the age in years to get that systolic pressure. If the patient has a history of cardiac disease, prematurity, chronic lung disease, or renal disease, we want to limit our normal saline boluses to 10 mLs per kilogram and reassess for fluid overload. Okay, protocol 40 is our nausea and vomiting protocol, and the first question we need to ask is, are there serious signs and symptoms of hypotension, poor perfusion, or shock? If the answer is yes, we're going to immediately start treating our hypotension with our normal saline boluses of 500 mLs. We may repeat up to 2 liters to obtain that systolic blood pressure greater than 90 millimeters of mercury, and then we're going to treat the nausea with our Zofran. Now, our Zofran doses are the same for our adult, 4 milligram IV, IO, IM, and the advanced provider may repeat times 1. For our intermediate providers, they can treat the pediatric patient as long as they're over the age of 6 months old with Zofran at 0.15 milligrams per kilogram IV or IO. If the patient is having abdominal pain, we're going to exit to the pain control protocol, protocol 7. If no abdominal pain is present, we want to establish an IV at a TKO rate, and if the patient improves, transport to the hospital. But if no improvement, we can administer normal saline boluses, 500 mLs, and then 150 mLs per hour. And for the IMP level providers, the boluses will be 20 mLs per kilogram to obtain and maintain a BP that is age specific. Protocol 41 is our newborn neonatal resuscitation protocol, and this protocol basically mirrors the inverted pyramid of neonatal resuscitation. It also discusses airway suctioning to clear amniotic fluid and meconium aspiration for our paramedic providers, and we are going to cover meconium aspirators in the skills portion of this protocol training. Protocol 42 is our overdose, poisoning, and toxic ingestion adult protocol. And this deals with overdoses of beta blockers, calcium channel blockers, and tricyclic antidepressants, as well as organophosphate poisoning, cyanide, and carbon monoxide. And in the instance of cyanide and carbon monoxide, it asks us to exit to the carbon monoxide smoke inhalation protocol, protocol 23. Okay, protocol 42 also covers narcotic overdose. At the top right-hand corner, there's a note on administration of naloxone. You can administer up to 2 milligrams. IV, IO, IN, or IM. However, we give naloxone to affect adequate oxygenation and ventilations. We do not give it to restore consciousness to our patients. For our beta blocker or calcium channel blocker overdoses at the IMP level, we will be administering glucagon, 3 milligrams IV or IO. We want to consider cardiac external pacing for severe cases of bradycardia. Also, calcium chloride at 1 to 2 grams IV IO over 3 minutes. and dopamine as our pressor, 2 to 20 micrograms per kilogram per minute. For our tricyclic antidepressant overdoses at the IMP level, if the QRS is greater than 0.12 seconds, so we have a wide QRS, we're going to administer the sodium bicarbonate, 50 milliequivalents IV-IO, and you can repeat in 5 minutes if the QRS remains wide. Now for our organophosphate poisonings, we have the nerve agent antidote kit, the Duodote, or the two medications that are in the Duodote, depending on how we're carrying it, is atropine, 2 milligrams, IV-IO-IM, every 5 minutes if symptoms persist, and those symptoms are the symptoms of sludgem, salivation, lacrimation, urination, defecation, GI upset, emesis, and muscle twitching. And we will also administer prolixidine, or 2-PAM, at 1,800 milligrams IV-IO or IM. And as I said before, if your patient is a cyanide CO or smoke inhalation exposure patient and we consider cyanide poisoning, we're going to exit to protocol 23. Okay, protocol 43 is our overdose poisoning toxic ingestion pediatric patient. Again, it's broken down between beta blocker overdose, calcium channel blocker overdose, tricyclic antidepressant overdose, organophosphate poisoning, and cyanide carbon monoxide. Asks you to exit to protocol 23. Top right-hand corner here, we have our Narcan doses. We're going to cover those in the next slide. Okay, so for our advanced providers, in the instance of narcotic overdose, they can administer naloxone to the pediatric patient, and the dose is 0.1 milligrams per kilogram, and they can only administer it IN or IM. And remember, Narcan is titrated to the effect of adequate oxygenation and ventilation, not given to restore consciousness. Now, for the INP level provider, they can administer naloxone IV and IO as well. Same dose, 0.1 milligrams per kilogram. Okay, so for our beta blocker or calcium channel blocker overdoses, the INP level providers will be administering glucagon at 0.5 milligrams IV-IO, max of 2 milligrams. You want to consider cardiac pacing for the severe cases of bradycardia. And calcium chloride, 60 milligrams per kilogram, IV-IO over 3 minutes. Dopamine is your pressor of choice at 2 to 20 micrograms per kilogram a minute. For our tricyclic antidepressant overdose patients that are pediatric, our IMP level providers, you're going to be looking at your ECG. Is there a wide QRS greater than 0.10 seconds? You're going to administer sodium bicarbonate at 1 milliequivalent per kilogram IV-IO, and you can repeat in 5 minutes if those QRSs remain wide. For organophosphate poisoning or nerve agents, our IMP level providers will be administering atropine, 0.05 to 0.1 milligrams per kilogram IV-IO or IM. This is every 5 minutes as long as the symptoms of sludgem persist. Also, you will be administering prolixidine or 2-PAM at 25 to 50 milligrams per kilogram IV-IO or IM. And for cyanide CO and smoke inhalation, again, you will exit to protocol 23. Protocol 44 is our pulmonary edema CHF protocol. Okay, so the pulmonary edema CHF protocol is broken down between mild, moderate, and cardiogenic shock. And for the mild pulmonary edema patient, the advanced through paramedic level provider is able to administer nitroglycerin at 0.4 milligrams sublingual, and they can repeat this every 5 minutes 3 times. They're also going to administer nitro paste, 1 inch, to maintain a systolic blood pressure greater than 90 millimeters of mercury. Now, if the patient is a moderate pulmonary edema patient, all provider levels will initiate CPAP procedures and also administer nitrosublingual and PACE if they have not already done so. The INP level providers in the moderate pulmonary edema patient will administer diuretics, furosemide, at 0.5 milligrams per kilogram IV if the patient is not already prescribed furosemide. And if the patient is prescribed furosemide, they will administer 1 milligram per kilogram IV. Now, the cardiogenic shock patient, the INP level provider will administer dopamine at 5 to 20 micrograms per kilogram per minute, IV-IO, and they're going to titrate to maintain that systolic blood pressure greater than 90 millimeters of mercury. Okay, so just a note on this protocol, if BLS has already treated the patient, be aware they may have began nitrotherapy already. Same is true for the cardiac chest pain protocol. And also CPAP. We want to begin at 0 centimeters of H2O PEEP, or positive end expiratory pressure, and slowly titrate to achieve a positive pressure of 5 to 10 centimeters of H2O. And we're going to cover this extensively in the skills training. The IMP level provider do not administer furosemide during pregnancy, or if hyperkalemia is suspected. And if cardiogenic shock is suspected, administer dopamine, 5 to 20 micrograms per kilogram per minute. Protocol 45 is our respiratory distress adult protocol. Now, this is broken down between a wheezing and a stridor patient. So for our wheezing patients, all provider levels will be administering albuterol, 2.5 milligrams in 3 mLs, normal saline, times 3 as needed, as well as CPAP. Our IMP level providers will be administering methylprednisolone or solumedrol at 125 milligrams IV-IO or deep IM, and mag sulfate at 2 grams IV-IO over 5 minutes. So our patients that present with stridor, all provider levels will have the ability to administer CPAP if indicated. Our IMP level providers will nebulize epinephrine, 2 milligrams of 1 to 1,000 in 2 mLs of normal saline, as well as administers methylprednisolone or solumedrol at 125 milligrams IV-IO or deep IM. Protocol 46 is our respiratory distress pediatric protocol. And again, it's broken down between a wheezing and a stridor patient. Wheezing is broken down further as to whether or not the patient is under 1 year of age, or whether or not this is their first wheezing episode or this has happened before. Okay, so for our wheezing patient over 1 year old, all provider levels will be administering albuterol, nebulized at 2.5 milligrams in 3 mLs, normal saline, times 3 as needed. If there is no improvement, the EMT will administer the EpiPen greater than 30 kilograms and the EpiPen Junior if the patient is less than 30 kilograms in weight. Now, if that patient is under 1 year old and this is the first wheezing episode, all provider levels will administer albuterol nebulized 2.5 milligrams in 3 mLs of normal saline times 1 as needed. If this is not the first wheezing episode, albuterol nebulized at 2.5 milligrams in 3 mLs normal saline times 3 as needed. Okay, continuing with the wheezing patient that is over 1 year old, the INP level treatment. They will also administer the methylprednisolone or solumedrol at 2 milligrams per kilogram IV, max dose of 125 milligrams. And if no improvement, they're going to administer epinephrine 1 to 1,000 at 0.01 milligrams per kilogram IM to a max of 0.3 milligrams. Now, if that patient is under 1 year old and this is their first wheezing episode, of course, the albuterol 2.5 and 3 mLs normal saline times 1 will be administered by all provider levels. And if no improvement, the INP level can administer epinephrine at 1 to 1,000 nebulized, 2 milligrams of 1 to 1,000 in 3 mLs of normal saline. Okay, so we just went over the patient who is under 1 year old, and this was their first wheezing episode. Now we're going to talk about the patient who is under 1 year old, and this is not their first wheezing episode, or they have a history of asthma. For all provider levels, they're going to administer the albuterol, 2.5 milligrams in 3 mLs of normal saline times 3, if no improvement. For the INP level provider, you will administer the methylprednisolone or solumedrol at 2 milligrams per kilogram IV to a max of 125 milligrams. Okay, so in protocol 46, now we're going to look at the patients that present with stridor. And for all provider levels, for the EMT, you're going to administer the EpiPen. Patients greater than 30 kilograms, the EpiPen IM, and for patients less than 30 kilograms, the EpiPen Junior IM. For the INP level providers, you're going to administer epinephrine 1 to 1,000 nebulized, 2 milligrams in 3 mLs of normal saline. And if no improvement, you're going to administer epinephrine 1 to 1,000, 0.01 milligrams per kilogram IM to a max dose of 0.3 milligrams. Also, the administration of methylprednisolone or solumedrol at 2 milligrams per kilogram IV to a max dose of 125 milligrams. Okay, protocol 47 is our seizure protocol. Okay, so the first question we want to ask in the seizure protocol is the patient actively seizing? If the answer is yes, our I and P level providers are going to be giving the same anticonvulsant that they are in their current protocols, and that is midazolam or Versed at 5 milligrams IV, IO, IM, or IN every 3 to 5 minutes as needed to a max dose of 10 milligrams. Now, we do want to assess, and if we have active seizing in known or suspected pregnancy greater than 20 weeks gestation, we will administer magnesium sulfate at 4 to 6 grams IV/IO over 5 minutes for eclampsia. Protocol 48, our stroke and TIA protocol. No real change from your current protocol. You will be assessing the patient using the Cincinnati Pre-Hospital Stroke Scale. Protocol 49, our tachycardia adult protocol. First thing we need to ask is our patient stable or unstable? So let's take a look at this. Tachycardia adult for the I and P level provider. If the patient is unstable, has serious signs and symptoms, and the heart rate is typically greater than 150 beats per minute, we will be administering Versed to sedate the patient, 2 milligrams IV/IO, IN, and you can repeat to a max dose of 10 milligrams. And we will synchronize cardiovert our patient. Also need to consider adenosine, 6 milligrams IV/IO if regular and monomorphic, and you can repeat that at 12 milligrams if needed. Now, if that patient is stable, but the QRS is wide, which is a QRS greater than 0.12 seconds, if it's regular and monomorphic, we will administer the adenosine, 6 milligrams IV/IO, and you can repeat at 12 milligrams if needed. Also, consider amiodarone, 150 milligrams IV/IO over 10 minutes, and you can repeat that one time if needed. If the rhythm does convert from amiodarone, we need to hang that maintenance infusion of 1 milligram a minute IV/IO. And of course, we need to consider mag sulfate for torsades de poids, and the dose is 2 grams IV/IO over 5 minutes. Now, for our stable patients in tachycardia with narrow QRSs less than 0.12 seconds, we want to first attempt vagal maneuvers and then move on to adenosine, 6 milligrams IV/IO, if the rhythm is regular and monomorphic. You can repeat that at 12 milligrams if needed. Irregular rhythms, or adenosine does not convert the rhythm, you will be administering metoprolol at 5 milligrams slow IV push, and you can repeat that every 5 minutes to a max dose of 15 milligrams. And of course, 12-lead ECG procedures after rhythm conversion. Okay, and below is a chart for synchronized cardioversion. This can be found in the procedures section of the protocols, procedure 14. Atrial fibrillation, we want to start at 200 joules. Atrial flutter, 100 joules. Ventricular tachycardia with pulse, 100 joules. And supraventricular tachycardia, 100 joules. Protocol 50 is our tachycardia pediatric protocol. Okay, first question we need to ask is the patient hemodynamically stable? If the answer is yes, and the QRS duration is wide or greater than 0.09 seconds, we want to evaluate the patient with a 12-lead ECG. If probable VTAC, we need to consider adenosine at 0.1 milligrams per kilogram IV/IO, max dose of 6 milligrams, and prepare for synchronized cardioversion. Consider Versed for sedation at 0.02 milligrams per kilogram IV/IO or IN to a max dose of 2 milligrams. Synchronize cardiovert the patient at 0.5 joules per kilogram, and you may repeat at 2 joules per kilogram. Amiodarone, 5 milligrams per kilogram IV/IO should be considered, and that's given over 20 minutes. Max dose of 150 milligrams, and you can repeat that one time if needed. Okay, so for our hemodynamically stable patients with a QRS duration that is narrow or is less than 0.09 seconds, we want to evaluate with a 12-lead ECG, and if the rhythm is a probable sinus tachycardia, which means the infant's heart rate is less than 220 and the child's heart rate is less than 180 beats a minute, then we want to identify threats and underlying causes and exit to appropriate protocol. Now, if it is probable supraventricular tachycardia, infant's heart rate greater than 220, children's heart rate greater than 180, we want to attempt vagal maneuvers and administer adenosine at 0.1 milligrams per kilogram IV or IO, max of 6 milligrams, and we may repeat that at 0.2 milligrams per kilogram IV IO, max of 12 milligrams. Now, if we have no improvement after adenosine, we want to go straight to synchronized cardioversion. And if we have time, we can consider Versed at 0.02 milligrams per kilogram to sedate the patient, IV IO or IN, to a max dose of 2 milligrams. And our synchronized cardioversion doses are 0.5 to 1 joule per kilogram, and we may repeat at 2 joules per kilogram. Okay, so for our pediatric tachycardia patients who are hemodynamically unstable, we are going to consider midazolam, if time permits, for sedation. 0.02 milligrams per kilogram, IV IO or IN, max dose of 2 milligrams. We are going to synchronize cardiovert our patient at 0.5 joules per kilogram, and you may repeat at 2 joules per kilogram. And also, we're going to consider amiodarone at 5 milligrams per kilogram IV IO over 20 minutes. Maximum dose is 150 milligrams, and you may repeat this one time if needed. Okay, Protocol 51 is our ventricular assist device protocol, and this can be a left ventricular assist device or a right ventricular assist device. When we're doing an assessment on a patient with a VAD, we need to auscultate at the left sternal border to the upper abdominal quadrant. If we hear a continuous humming, then this means that the VAD is working properly. The pump is working. Also, when the pump is working, you will not have any palpable pulses, no measurable blood pressure, and no pulse oximetry readings. So you need to rely heavily on your clinical assessment of perfusion. Skin color and temperature, cap refill, mental status. If we do have signs of obvious death, we need to withhold chest compressions. So we need to determine whether or not our patient is stable or unstable. If they are stable, we're going to treat per appropriate protocol. However, if our patient is unstable, we need to consider that this may be another general medical problem, such as hypoglycemia, and treat appropriately. Also, we need to look for volume depletion and give rapid normal saline fluid boluses. Check an EKG for abnormal cardiac arrhythmias and treat appropriately. And also the controller alarming. Is the controller sounding an alarm? We need to treat for cardiogenic shock and change controller if instructed. Okay, so for the ventricular assist devices, we always contact the VAD implant center. We allow the patient's trained companion to stay with the patient, and we transport all of the VAD equipment with the patient. Now here's your VAD-capable EDs. Inova Fairfax Hospital, MedStar Washington Hospital Center, University of Virginia Medical Center, and the University of Maryland Medical Center. Okay, so again, for Protocol 51, become very familiar with the ventricular assist device protocol. Information on VADs can help you with troubleshooting procedures. At the left there is a picture of a patient that is wearing a ventricular assist device. Protocol 52 is your OBGYN childbirth, labor, and delivery protocol, and we have no change in our current protocols in the treatment of your pregnant patients. In this protocol, there is also a picture of the knee to chest position for the prolapse cord, shoulder dystocia, limb presentation, pregnant female, as well as an APGAR score. Protocol 53 is our OBGYN pregnancy-related emergencies protocol. Okay, so Protocol 53, there's a few questions we need to ask. Is our patient actively seizing? If our pregnant patient is seizing, we're going to administer mag sulfate at 4 to 6 grams IV-IO over 5 minutes, and follow that with midazolam or Versed at 5 milligrams IV-IM-IO. Repeat every 2 to 5 minutes as needed to a max dose of 10 milligrams. Also, we need to obtain an ECG. Now, if our patient is not seizing but is hypertensive, preeclampsia is defined as a systolic blood pressure greater than 140 and a diastolic blood pressure greater than 90. We need to consult medical direction before administering mag sulfate. For our advanced through paramedic providers, for a hypotensive pregnant patient, we need to ensure that the patient is lying in the left lateral position. And if they are and they still are hypotensive, we will administer normal saline boluses at 500 milliliters IV-IO to maintain a systolic blood pressure greater than 90 millimeters of mercury to a max of 2 liters. If no improvement, we're going to exit to the hypotension and shock protocol and treat appropriately. Now, for all provider levels, labor, we're going to exit to childbirth, labor, and delivery. Okay, Protocol 54 is our WMD ChemPack protocol, or our Weapons of Mass Destruction protocol. Now, this protocol is designed for organophosphate poisoning or nerve agents. In this protocol, the symptom severity of minor or major, that is, minor symptoms of respiratory distress and sludgum, salivation, lacrimation, urination, defecation, diarrhea, GI upset, emesis, and muscle twitching, and major symptoms, altered mental status, seizure, respiratory distress, or respiratory arrest, we are going to administer the Duodope kit, which we're going to talk about in the skills portion of this training. But the two medications that are contained in the Duodope kit are atropine and prolixidine. For the minor symptoms, we're going to administer atropine at 2 milligrams IV, IO, or IM every 5 minutes. The pediatric dose is 0.05 to 0.1 milligrams per kilogram until the symptoms resolve. And we're also going to give the prolixidine, or the 2-PAM, at 600 milligrams IV, IO, or IM, and the pediatric dose is 25 to 50 milligrams per kilogram. Now, for the major symptoms, we're going to administer atropine 6 milligrams IV, IO, IM every 5 minutes. Pediatric dose of 0.05 to 0.1 milligrams per kilogram until symptoms resolve. And we're also going to administer the prolixidine, or 2-PAM, at 1,800 milligrams IV, IO, IM, and the pediatric dose of 25 to 50 milligrams per kilogram. Okay, that's all for the 54 protocols within the new protocols. We're going to talk now about the procedures section. Of course, there's a disclaimer in the procedures section. These procedures may only be performed as trained, authorized by an OMD, and in accordance with the Virginia Scope of Practice maximums. The procedures listed here contain general instructions and protocols for their implementation. If using equipment not listed here, or in the event of conflicting instruction, follow the manufacturer's suggested settings and or procedures. Okay, so below is the table of contents for the procedures section in the protocols, and you are going to receive training during the skills portion of the protocol rollout on the mucosal atomization device, or the MAD device, the CPAP with inline nebulizer, and the different pressures we need to flow that out depending on whether or not you're using a nebulizer or not, the PET oxygen mask, the taser probe removal, the CAT tourniquet, and all medications that are new to Fauquier County, amiodarone, fentanyl, ketamine, Haldol, ibuprofen, Tylenol, lidocaine for anesthetic use for the EZ-IO, Afrin, and the Duodope. Also, we're going to discuss infusions, a review on dopamine, infusion of amiodarone, and our epinephrine 1 to 100,000. We're also going to talk about hydroxycobalamin. For our paramedic level providers, we are going to train on surgical and needle cricothyrotomy, the equipment that is in the Chinook cricothyrotomy kit, and also meconium aspirator for our pediatric patients with meconium staining. Okay, so the policy section. This section is designed to help answer any questions that you as a provider may have in the course of patient care. Again, you as a provider, this is your responsibility to become familiar with the policy section within these protocols. And this is what the policy section will cover. Below is a picture of the table of contents for policies. We have abuse and neglect, air medical utilization, ambulance patient destination, criteria for death, deceased subjects, direct admission, discontinuation of pre-hospital resuscitation, documentation and confidentiality, extraordinary care not covered in these protocols, hospital reporting and online medical control, and impaired field providers. Inability to carry out a physician's orders, infant abandonment, infection control, inter-facility transport of acutely ill and injured patients, medical emergency custody orders, provider field status, quality improvement, refusal of treatment and transport, treatment of minors, verification of on-scene medical personnel, and a Virginia durable do not resuscitate order. The medication reference section references all medications that will be carried within Fauquier County. The color-coded medication reference, or commonly referred to as the Broslow tape, just a note on this, we've circled here the average All of these medications and their dosages are based upon the average of 6.5. For instance, with this pink medication reference, color-coded reference, the weight is 6 to 7 kilograms and the average is 6.5. Okay, contained in the EMS resources section, we have the contact information for the Critical Incident Stress Debriefing, the Virginia Office of EMS, Adult Protective Services, Child Protective Services, the contact information for Chemtrec for your hazmat situations, your medical examiner, poison control. We also have the address and contact information for area hospitals. Now, there are some references for you as a provider with medications, the dopamine drip rate chart. You also have a mixing D10% and D25% for your hypoglycemic patients, pediatric. You have IV drip rate chart and an APGAR score. Continuing with the reference section, we have the Glasgow Coma Score Adult, Glasgow Coma Score Pediatric, the Trauma Score, the Field Trauma Triage, the Field Stroke Triage Decision Scheme, the Rule of Nines for adults and pediatrics, and the Start Triage and Jump Start Triage. Okay, this concludes Module 3, the Intermediate and Paramedic Training for the 2014 Medical Treatment Protocol Guidelines. You have now completed the online portion of your protocol rollout training, and your last step is to attend the Intermediate and Paramedic Skills Training. Once again, thank you for completing this training.